Welcome, everyone. My name is Dr. Melanie Carminati, and you are tuning into the Know and Do Better podcast, where we chat with experts on a variety of different health, wellness, and holistic topics. Today, we have the pleasure of speaking with Dr. Mairin Jerome, who specializes in physiatry with subspecialty in regenerative medicine, and we will be chatting about regenerative medicine. Hi, Dr. Jerome. Thank you so much for being here. I really look forward to speaking with you today.
Hi, Dr. Carminati. Thank you so much for having me. It's a pleasure.
So I'm just going to give a quick introduction for those who are not familiar with Dr. Mairin Jerome. She is a physiatrist with subspecialty training in regenerative sports and spine medicine. She completed her medical doctorate at University of Vermont College of Medicine, her residency in physical medicine and rehabilitation at Emory University, and fellowship in interventional orthopedics and regenerative medicine at Centeno Schultz Clinic in Colorado, where the founders helped pioneer the field of regenerative orthopedics. Dr. Jerome is trained in using X-ray and ultrasound guidance to precisely deliver regenerative medicine-based injections to areas of injury or degeneration throughout the spine and peripheral musculoskeletal system. Dr. Jerome has also co-authored multiple peer-reviewed papers and textbook chapters in her specialty. Dr. Jerome, thanks again for being here. I wanted to start off the conversation with the general opener of what is regenerative medicine?
So it's a great question. Regenerative medicine is the concept of using your body's own inherent healing mechanisms to stimulate repair of tissue or decrease of inflammation of a chronically inflamed or injured area. So it actually goes all the way back to Hippocrates in 500 BC, who would use apparently a hot poker in the armpit of patients who had shoulder injuries to help scar down the tissue and provide greater stability and overall decrease pain. We have since made tremendous progress and improvement since then in terms of the methods through which this type of regeneration is stimulated, but it goes back thousands of years and progressed through veterinary medicine, where they use a similar technique of using electrocautery for injured tendons in horses called pin firing, which now is considered to not be as humane of a practice. However, that basic underlying concept is really what is the foundation for regenerative medicine, which is stimulating proliferation response within the body to help lay down stronger, healthier, more organized tissue in the case of tendons or ligaments, or help to stabilize cartilage, decrease inflammation in the microenvironment in an inflamed joint, for example, with arthritis. And we can go into a number of different types of things and the different types of regenerative medicine treatments that are available in more detail.
Yeah, amazing. It's so powerful when interventions are utilizing the innate healing power that our bodies have. I mentioned your residency and fellowship. I'd like to hear a little bit more specifically about the fellowship, because it's so specialized, and the clinic in Colorado, as I mentioned, is pioneering really for the field of regenerative orthopedics. Can you touch a little bit on that fellowship?
Absolutely. So I went into physiatry because I realized it was a specialty. Not very many people are familiar with it, but it's called physiatry or physical medicine and rehabilitation. And what we do is really focus on the whole person and look at every component of life to help them have the most optimal functioning. And it's really a specialty that is committed to quality of life. And so we treat people with various types of injuries, ranging from spinal cord injury to brain injury to musculoskeletal sports and spine medicine, which is what I have further subspecialized in. And halfway through my residency, I went out and visited a colleague who was training at the Centeno Schultz Clinic, where I did my fellowship, and saw our field of physiatry looking at everything from a holistic biomechanical perspective, but taken to the next level. So for example, the person who I was shadowing, who was a few years ahead of me, who had also gone to Emory for residency, was treating a patient for shoulder pain. And he was pointing out that the patient came in for a shoulder issue, had a rotator cuff tear, but on his exam, there was some findings that there were some low-grade nerve injuries coming from the neck. So we got an MRI, and it turned out there was a little bit of compression of one of the nerves in the neck that was leading to weakness of the muscles in the shoulder girdle, which then led to the problem of the shoulder injury. So in order to effectively treat the shoulder, he was also addressing addressing the nerve pinching in the neck as well to get the nerve back online so the muscles could fire better. And so the overall response to treatment in the shoulder would be improved. So it was the first time I really had seen, and physiatrists have that sort of mentality to begin with to find the root cause of something, but it was the first time that I had seen the application of regenerative medicine used so effectively to actually treat the root cause while also treating a resultant injury. Many traditional medicine has used steroids and surgery, which, they both have their role and are great when needed, but they do have their limitations, especially with injection based type of treatments. With steroids, there are many systemic side effects and other problems with decreasing the health of tissue, causing increases in blood sugar, changing hormonal axis, decreasing bone density. There are many risks that go along with using steroids for injections, even though they're putting out inflammation for a short period of time. So you need to be very limited and targeted when using them to treat somebody for pain. But with regenerative medicine, it's actually the tissues that we use, which can be blood-based with platelets. It can come from bone marrow. It can come from fat, which is a bit of a different story. But they're all what I was trained to use. They're called autologous products, meaning they're from your own body and they're re-injected to help stimulate healing. So in fact, there's much less limitation in terms of how to approach treatment with these therapies.
So the important thing that you mentioned for me is that physiatry is really aimed at getting to the root cause of the dysfunction or pain. And I feel that with the other more traditional medicine, that it really is just treating the symptoms. And I see that for myself with patients who are coming in for physical therapy, that they may go for some kind of steroid injection and they have that temporary relief, but it really doesn't stimulate anything that would be promoting healing within the deeper structures and tissues where there is the impairment. I think that's really important for everyone to understand that physiatry is really just getting to the root of the issue. So in regards to regenerative medicine, are there, briefly mentioned this, what are the different goals based on different procedures and treatments? Because I guess it really depends on the diagnosis, right?
Correct. And that's a great question. And this gets a little bit back to your initial question about my fellowship. So the reason that I wanted to train at the Centeno Schultz Clinic, it was the fellowship was entirely devoted to regenerative medicine. So I really learned how to use all of the different types of products that we have available that we can make from somebody's blood or bone marrow to inject all over the body. And so Centeno Schultz Clinic, they had developed a model called the SANS methodology, which stands for symmetry, articulation, neuromuscular, and stability. So that is a way to look at, any joint or any portion of the body to see, are the nerves firing well to control the muscles? Are the joints articulating well and smoothly across the surface of each other? Or is there some breakdown in the cartilage? Are the ligaments holding well, or is there some instability there that's causing further breakdown of the cartilage? And are things symmetrical from side to side? Oftentimes, someone may have a quote unquote normal exam on one side, but when you test against the other side, they actually have subtle findings of tenderness or some kind of issue or a little bit of decreased strength that provides a biomechanical imbalance that can then lead to injury. So all of these things need to get addressed. And of course, this is all working with physical therapy and exercise to have the most optimal outcome. But to get at your question, different regenerative medicine treatments have different goals. So starting from the very beginning, there's kind of few different types of treatments. There's something called prolotherapy, which has actually been around since the late 1800s, described as a sclerosing solution to help make ligaments stronger. This eventually was termed prolotherapy, or was coined prolotherapy by Hemwall and Hackett in the 1950s, who used different types of agents to scar down tissues, including ligaments and tendons, to help stabilize different parts of the body in the pelvis and the spine, for example, and decrease musculoskeletal pain. Today, we still use prolotherapy. There's different agents that you can use. The most common that I use in my own practice is actually dextrose, which sounds crazy, but it's just sugar water. And the action of the dextrose in the injection stimulates a little bit of healing in whatever tissue you injected in, for example, a ligament or a tendon, to help bring more blood to that area and help to tighten up the ligaments and tendons. So, and just a basic understanding of how those things work. Tendons and ligaments are made of collagen fibrils that are very tightly packed together, kind of like a shoelace. And so when they're healthy, they're very tight and their fibrils are organized and linear. And over time, as injuries occur, we get small tears in these different fibers that then don't heal back down in as tight of a pattern. So they're a little bit wavier, a little bit weaker, and can cause a little bit of chronic inflammation and pain. So the goal of any type of regenerative medicine injection, for example, in a tendon, and that term is called tendinopathy, which is not acute inflammation, it's more of a chronic inflamed ongoing problem. Happens very commonly in the rotator cuff, it can happen in the hip, it can happen in the elbow. And so you can use, depending on how severe the injury or how severe the pain is, you can choose prolotherapy, which is kind of like the weakest tool that we have in the arsenal, but can be very effective for minor pain issues. Then the next step up is platelet rich plasma, which is from our blood. So it's just like when you go and get your blood drawn for lab work, but we take the blood, we spin it down, concentrate the platelets, because the platelets themselves have many different growth factors and molecules in them. When they come in contact with an injured area, they release all of these growth factors and tell the surrounding tissue to heal whatever area is injured. And it turns out that tendons, ligaments, joints, areas of the spine, they don't have a very robust blood supply to begin with. So, for example, if you tear a muscle, the muscle has a very rich blood supply. So it's easy for our bodies to heal those areas. But these other areas, especially as we age, our healing capacity diminishes. And so what we've found is that by taking the platelets out of the blood, concentrating it down, and then injecting it precisely into that area of injury, whether it's a tendon, ligament, potentially in a joint, which is a bit of a different process, which we can talk about later, it stimulates the body to bring in stem cells and different healing factors to make the environment healthier, to lay down new collagen, and overall improve the integrity of the tissue. One step up from that is a mesenchymal stem cell injection. There's been some controversy in the last decade or so in terms of very specific about that terminology, and the current thought process is to use mesenchymal signaling cell. But the bottom line is we can use cells that are a bit more robust in terms of their therapeutic efficacy. You can harvest them. Most well-studied type of cell is autologous or from your body stem cells from bone marrow. So it's like a blood draw, but we tap into the back of the pelvis, pull out some of the bone marrow, concentrate it down to try and get a higher yield of cells, which then creates a more robust response in terms of healing. And so this can be very effective for ligament tears. For example, you can see ACLs that have been torn. As long as it's not torn greater than 1 centimeter and pulled apart, we have excellent healing capacity by injecting under X-ray guidance into the tear. And even 6 months to a year later, you can see essentially regrowth of the tendon, which is pretty remarkable when you think about it in terms of avoiding surgery for many people, and also maintaining the native structure of the actual ligament in there. Because when you have a surgical repair, the ACL is actually made of 2 bands that do 2 slightly different things in terms of your movement and function. And if you have a surgical repair that replaces the ACL with a graft from a cadaver or a hamstring or another part of your body, then you end up with 1 band, which then inherently changes your mechanism. So if we're able to keep the native anatomy and just improve the tissue healing, that's kind of the goal with regenerative medicine, is to keep people with their native anatomy.
Absolutely. I was just speaking to a patient who has an ACL tear, partial, and she had gone for a surgical consult. She herself is actually in the health and wellness field. And when the surgeon explained that he would take part of her hamstring, she was like, but what about my hamstring afterwards?
Mm-hmm.
So I think the goal that you mentioned of regenerative medicine is so important for people to understand, because many people want that. Many people want to keep their anatomy as is, and work with, the healing that can be stimulated via these procedures. So let's talk about joints. How are the treatments with joints different in degeneration in the joints?
Yeah, it's a great question. So initially, when this field came out, and I should say, by the way, so it started in the oromaxillofacial and dental world in the 1980s, and then there's a orthopedic surgeon in France named Philippe Hernegout who began to use bone marrow concentrate for patients with hip osteonecrosis, and he has pioneered many of the most impressive studies actually in joints specifically. So it's fascinating what happens in our joints. So it turns out that the stem cells in our joints have different ages. So the stem cells in our hips, for example, in terms of being able to repair themselves and have a healthier cartilage as we get wear and tear over time, they're of an older age in our body compared to our knee cells or ankle cells. So that's one of the reasons why for many people hips wear out a little bit more quickly. So we're learning all of these new concepts in biology and as we figure out how to target regenerative medicine. So initially, I think people were very hopeful that with stem cells and the advent of regenerative medicine, that we would be able to resurface whole joints and grow a whole bunch of new cartilage and be, like a teenager again. And it turns out that's actually not quite the way that it works. But for most patients, depending on the severity, PRP works very well for mild to moderate knee arthritis, for example. On average, when pooling the data together, on average, a 12 months plus improvement in pain and function, which we would define success as greater than 50% improvement in pain and function. And bone marrow based stem cells can help anywhere between, for moderate to severe arthritis, anywhere between kind of the 2 to 7 year mark, depending on the patient's response to that. And so the way that they work, really, in some cases, we do see a little bit of cartilage growth, but it's really only in about 20% of cases. And it's typically not the same type of cartilage that is in our younger joints. It's a little bit more fibrous. But what we do see is a very significant improvement in pain and function. And the reason for that is because we change and alter the microenvironment from being in a pro-inflammatory, irritated, painful state to a less inflammatory, healthier environment that just helps people function and feel better within the joint. One of the other things that's important to address was one of the things I really appreciated getting out of my fellowship training, is that part of the reason people get arthritis, in addition to genetic factors, lifestyle, diet, things like that, are instability within the joint that causes excessive motion and wear and tear of the cartilage. So it's very important when assessing arthritis to look at the structures outside of the joint, the ligaments, the tendons that keep the joint stable and in place, and of course the muscles as well, which is the patient's job to keep the muscles strong so that the joint can function well. And then it's our job to look at the whole picture and stabilize and tighten up any ligaments that are too loose to prevent excessive movement. Because people often talk about bone spurs, and bone spurs are really a response to excessive movement. Because if you're having too much movement, then you want to create a little bit more shelf to keep things stable. So that's something that we address quite a lot as well. And I will say also, it's an amazing treatment modality, and it really serves to provide a bridge between conservative therapy, where people try physical therapy or maybe some simple injections, and they don't really get to where they want to be, but they're not really a candidate for surgery, or they want to try something else first. And it's an interesting and exciting field. Unfortunately, we haven't caught up yet. We do have very high level evidence for efficacy for much of what we do, but we haven't caught up yet with insurance reimbursement. So unfortunately, most of these treatments at this point are out of pocket, makes it inaccessible for many people, unfortunately. But I do think that in the next, hopefully, decade or so, it will begin to replace some of the other options that people have. So if it were me, I would always want to try something a little less invasive than going for surgery first, unless it was absolutely necessary.
My physical therapy patients, when I have the conversation with them, okay, so this is our plan. This is what we're going to work on. Let's see how this goes. And then the next step, I feel like many times I'm the first to inform them about regenerative medicine. And why do you think there's that lack of knowledge out there for like the general public of regenerative medicine? Is it correlated to the insurance coverage, or what do you think?
There's a few different things happening. We haven't caught up. It's not part of the mainstream. Many physicians are not very well educated about the field. And there's a lot of people who are doing things that are quite unethical that basically amount to patient fraud. So there are many chiropractic clinics and other people who are offering these therapies. They're being offered to patients who are not good candidates for it without an appropriate workup. They're not selecting the correct type of treatment to use for those patients, or they're just making claims that are completely false. So one of the things that's very important to stress is the difference between, I may have just cut out, stem cells from your own body versus something from another person's body. So there's autologous, which means auto, from self, or allogeneic, which is not from the self. There's many, many companies out there that are selling products that are like umbilical stems, quote unquote, stem cells, or Wharton's jelly stem cells, or amniotic stem cells that are, taken from birth products and then put in freeze dried and put in a little bottle and then reconstituted and re-injected. There's a great podcast called Bad Batch that documents a lot of what's going on here, but essentially they're not FDA approved. They do not have any live stem cells when actually checked in a lab. If you're going to use birth tissues, they have to be cultured in a lab and then delivered in a totally different way than what's currently being marketed by many practices. And they do have some efficacy in terms of having growth factors. So they're actually similar to a PRP. So they would be appropriate for certain patients who aren't healthy or have some other issue, but you have to be very careful with which product you select and which patients would be a good candidate. And in my opinion, it's safer to always use cells from your own body. And so what's happening is there's many clinics, few chiropractic clinics in particular, who are marketing these products as stem cells, which they're not. They're also telling people that, especially the older population who have many of these degenerative arthritic problems and pain as a result of that, that their stem cells are too old to use, and therefore they need these young birth tissue type products, which is actually false. If you grow them out in a lab, you don't grow any stem cells from the amniotic or birth tissue products that are come in a little bottle. But we've had patients 70s, 80s, 90s who we can get a very robust stem cell yield from if you are well trained and know how to do a good bone marrow aspiration and concentration technique. So you have many, many, many more stem cells in your own body than you would from these amniotic products. My point is there's a lot out there that's happening that is really, for the profit of unethical practitioners, essentially, who are doing this incorrectly, that kind of give the field a bad name. And then there's many of us who do have an interest in research and pushing this field forward and really believe and have seen incredible results. And the research, it really is quite promising. I mean, there have been different areas, a few randomized controlled trials, gluteus medius tendinopathy being one of them for PRP, bone marrow-based stem cells in the knee. We can talk a little bit more about the research there, but the research is building. The other issue as well, I know this is a long-winded answer to your question, but the other issue is that because this is different than a drug, we can't isolate it in a lab and look at one thing. What's happening biologically is so incredibly complex. We can never actually measure completely what's happening. So it took a little while for people to figure out, number one, how to dose PRP. So it turns out that the concentration matters. The number of platelets that you puts in matters. You want a higher dose for joints than you do for tendons. You want to use more platelets for people who are older than are younger. All of these things make a difference. So in the initial studies, people were not reporting how many platelets they were putting in, if it was white blood cell rich versus poor, what the concentrations were. As we learn more and gain more knowledge and understand some of the nuances of how to best deliver these therapies, we're getting better at understanding what is actually working, how to look at the data. In addition to that, PRP and stem cells, really, it's on your body's timeline in terms of healing. So if you do a study and you inject steroid in someone, they're going to feel better for about 2 weeks. It's probably going to be temporary because it's steroid, but in 2 weeks, they're going to feel better. With PRP, people actually feel worse usually for the first 48 hours because it works by creating acute inflammation, not chronic inflammation, which is over the long-term destructive, but acute inflammation, which is short-term healing response. People then feel back to baseline, and then it takes really about 6 to 8 weeks before you start getting improvement. So if you do a study and you compare steroid to PRP and you cut it off at 4 weeks, it's going to look like the PRP is not effective. But actually, if you wait longer and allow it to do its thing, starting at the 6 to 8 week mark, you will see market improvement. So all of these things factor in, the timeline that the studies are done for, and drilling down on these details are very important.
So my last question is, where do you see regenerative medicine evolving in the future?
So where I see it evolving, and my hope for the field in general, is that it gets incorporated into traditional mainstream medicine as an option for patients who, again, have failed conservative management, or they're not quite ready for surgery, or they're not surgical candidates, as an option that's in between. Really, what needs to happen is people need to work together within the field. It's wonderful to work with our surgical colleagues. Patients, none of this, what I'm saying is that patients don't need surgery or shouldn't try a steroid injection here or there. There's a role for all of this. So my hope and what I envision is that as we understand the data better select our patients in terms of optimizing results and outcomes, that regenerative medicine will become a standard treatment for patients who are good candidates based on the research that's emerging, to kind of fill in the gap between, patients with chronic pain issues that don't resolve and who don't need surgery.
Wonderful. Dr. Jerome, thank you so much. This was so informative, understanding of regenerative medicine, what it's aimed at, the goals, and where it's going, and what people might want to consider for their own well-being and healing. And I want to thank everyone else for tuning in to the Know and Do Better podcast. If you've enjoyed this podcast, be sure to like and follow us wherever you find your podcasts. You can also follow Inspira Physical Therapy and Pilates on Instagram at Inspira Physical Therapy, and check out our website at inspirapt.com. Be sure to stay tuned for our next episode. Thank you, Dr. Jerome.
Thank you so much, Dr. Carbonati. It was a pleasure to be here.